Hello, everybody, and welcome back to those of you that have been here before. And for those of you that haven't, welcome. My name is Kay Hoppy, and today we are going to go over 10 potential CCRN or PCCN type questions that you would find on your exam. And then we're also going to talk about some of the corresponding rationale. So if you'd be so kind over in the chat, if you could please tell me what city and state you're calling in from. I am in Oconomowoc, Wisconsin, which is located right between Madison and Milwaukee. And so I just love to know where my audience is from. We have Becky from Indy, welcome. Heidi, Cleveland, Ohio, welcome. Florida. Ethel, great to have you guys back. I'm starting to recognize quite a few names, which is wonderful. It's absolutely wonderful. We have Mobile, Alabama. We have Jordan in Milwaukee. Let's see, we have North Carolina and also Phyllis in Indianapolis, or excuse me, in Indiana. So welcome to you all. I do have, as we get underway, I have one quick question that I like to ask of everybody before we get going. And I'm going to go ahead and pop it up in the poll. And that is, I'd like to know, excuse me. Yes, I would like to know which, let me back up here a second. Go back to the poll. I would like to know which exam you're planning on taking. So many of you I know are here because you're going to be taking one of the exams, either the PCCN or the CCRN. And I like to get to know my audience a little bit before we get started. And so it looks like many of you that are here right now are after that CCRN designation. So wonderful. It's great to have you all here. And without further ado, then let's get on with our questions. I do have one announcement to make, however, and let me just back up just a moment. And that is that I just recently started my channel on YouTube. And so I wanted to let you know that all of you that are attending today, you will automatically get a replay, a recording of this session that's automatically emailed to you within a few hours after this particular session. But if you're unable to be at a session, I want you to know that you now can go on YouTube in order to be able to pick up on or get back into the content that you weren't able to get the last time or you weren't able to attend. So today we are talking about shock syndromes. So let's go ahead then and jump into our first question. So we have a 76-year-old male with a 3-day history of fever, vomiting, and productive cough. He's admitted to the ICU with the following assessment findings. We see that he has a blood pressure of 78/50, heart rate of 156, respiratory rate of 32, and a temperature of 102.8. Urine output was really negligible when they put in the Foley. Which of the following hemodynamic profiles for this patient would be most likely? So I'm going to have you put your answer over in the poll section. Okay, let's go ahead then and let's take a look at our answer. Our answer is B. Now let's talk about this a little bit more in depth here. So I noticed that several of you hopped on the fever, the vomiting, the productive cough, and where your mind was taking you was down the trail for sepsis. And so many of you thought, okay, this person looks like they're becoming septic. And again, you know, when we talk about the hemodynamic profile for somebody with sepsis, I'm sure for option C, you're keying in on the fact that the patient has an SVR of 498. normal being 800 to 1200. So we know then that this person is dilated out, and we see that in sepsis. However, keep in mind, and this is where option C really is pretty tricky, keep in mind that the SVR and the cardiac output and index are inversely related. So as the SVR goes down, what we automatically anticipate seeing is that the cardiac output and index will go up. And as you can see that this patient in C has a low cardiac output in the presence of an SVR of 498. And actually what we would see is we would see an elevated cardiac output because the SVR is so low. And so that throws out option C. So, okay, what other kinds of things can I think about? Well, we know that when somebody initially comes in and they're heading down, we suspect the septic trail, we know that they present really dry. So let's go ahead and take a look at B. B is, by the way, the answer. And what we can see is cardiac output is low and SVR is very high. And that's an appropriate relationship between those two parameters. So when the cardiac output drops, we automatically anticipate the SVR will go up. And here we do see a drop in cardiac output. Again, cardiac output normal being about 4 to 8 liters. And so we see that drop and we see the SVR go up. So the patient's clamped down. We also look at right and left ventricular filling pressures. And so to look at right and left ventricular filling pressures, we look at the right atrial pressure for right-sided filling, normal 1 to 5. So that seems normal, but within the assessment findings and the rest of the parameter, it really is indicating a decrease in filling. Wedge pressure, which we know to be pulmonary arterial occlusive pressure, PAOP, is 2. And, you know, the wedge pressure, which correlates with the pulmonary artery diastolic pressure, in most cases, they correlate within 4 millimeters of mercury. With a wedge pressure of 2, normal is about 6 to 10, 6 to 12. And so this patient has low left ventricular filling. And so we see the pressures low, we see the cardiac output low, we see the SVR high. So let's see, how about option D? Because that was one that was chosen as well. Option D is really pretty normal, is it not? Patient has 4 liters of cardiac output, right atrial pressure is 5, pulmonary artery pressures are 20 over 12 with a wedge at 10, and an SVR of 1100 dynes. And so actually option D is a pretty normal set of hemodynamic parameters. Now, when we take a look and we compare the different types of shock, we have hypovolemic, we have cardiogenic, and we have distributive. And so hypovolemic and cardiogenic, those speak for themselves. But a lot of times when you talk about distributive shock, people ask questions as to what falls under that category. When we talk about distributive shock, we're talking about things like neurogenic shock, and we're also talking about septic shock. So when we talk about distributive shock, we're talking about maldistribution of blood flow. And isn't that what we see when a patient is septic? We see that because of massive vasodilation, which drops their SVR, by the way, massive vasodilation causes maldistribution of flow. And that leads to all kinds of things like the hypotension and the lack of renal perfusion and the acute renal failure that goes along with that, decreased liver perfusion, and just overall decrease in organ perfusion. So what we see then, kind of as an overview, with hypovolemic shock, like we saw in our question here, cardiac output goes down, SVR goes up. Those are inversely related parameters. The wedge pressure, pulmonary wedge pressure, which we now, of course, call PAOP, goes down, and the CVP goes down. When we talk about cardiogenic shock, we're going to get into some questions, of course, on that as well. Cardiogenic shock, the cardiac output drops, the SVR goes up, and filling, both right-sided and left-sided filling pressures go up. So that's cardiogenic shock. Now take a look at distributive. And in this particular instance, the type of distributive shock that we're talking about is the patient with septic shock, or this is, one of the options that people kind of took for this question. With distributive or septic shock, we see massive vasodilation. That's why it has two arrows next to it. That drop in SVR, it's very massive, and it's related to many different factors, including endotoxin that causes massive dilation. Blood pressure plummets. Okay. However, when we look at cardiac output, we see that cardiac output is high. Well, that seems weird, right? Well, again, keep in mind they're inversely related. And the only reason cardiac output is so high, and it's really kind of a false picture of what's going on with the patient, the reason why the cardiac output is so high is because the SVR is so low and there's no resistance to flow. And then, of course, when we look at both right-sided and left-sided filling pressures, they're both low in distributive shock as well. Okay. So let's go ahead then and move on to question 2. Now you are caring for a patient with refractory hypoxemia, so it doesn't respond to treatment. This patient started on Flolan. When you talk about the patient's hemodynamics, because this section is talking about shock and hemodynamics, which of the following hemodynamic parameters would reflect the effectiveness of Flolan? And I will go ahead and pull up the poll. All right, let's go ahead and take a look at our answer. Our answer for this one is pulmonary artery pressure. We know that Flolan is a pulmonary vascular dilator. So we would expect then, if somebody has refractory hypoxemia, we can attempt to improve oxygenation through pulmonary vascular dilation. And what we would expect then is we would expect to see the effect of this on pulmonary artery pressures. Now, let me take one more step here and say this. When you have hypoxia, the pulmonary vascular bed responds to that by vasoconstricting. So the automatic response that we would expect to see then in the presence of hypoxia with resultant hypoxemia, which is the clinical symptomatology or presentation of hypoxia, we would expect to see the pulmonary pressures go up. The patient develops pulmonary hypertension. If you have a hard time wrapping your head around that one, think about the person with chronic COPD, somebody that we like to call our 50-50 club members because they have a 50 PO2 and a 50 PCO2. People that are chronically hypoxic and hypercapnic, by the way, will have chronic pulmonary hypertension. We give Flolan as a pulmonary vascular dilator. We know it's working when the patient's pulmonary pressures decrease. Okay, let's take a look at question number 3. So you have a patient in cardiogenic shock. Patient has a mixed venous oxygen sample ordered, and so you're to draw that now in order to get an SVO2. So where in the world would you get, if your patient did not have an oximetric pulmonary artery catheter in place, where would you draw a mixed venous gas when a patient has a pulmonary artery catheter in place? Looks like you guys were all over that one, no doubt about that. So the answer to this one is the pulmonary artery, or the distal port of the pulmonary artery catheter. So taking a look at this, when we talk about the distal port, of course, it opens up at the catheter tip. There is always the question, and there's always the temptation when you have to draw off a pulmonary artery catheter. Well, gee, do I really draw off the distal port? Well, if you don't, and some people go ahead and draw their mixed venous sample off the proximal injectate or proximal infusion port. We call it the CVP, or right atrial port. It's the one that's blue, of course. That opens up at the 30 centimeter mark from the tip. So you know how the PA catheter has those little hash marks as you go along? The right atrial port opens up at the 30 centimeter point, 3 hash marks right there. And so it is in the right atrium. So the thing that you have to ask yourself is, would blood even be mixed in the right atrium? And the answer to that is maybe not as much as if we waited until that blood came into the right atrium via the superior and inferior vena cava, went down into the right ventricle, then it's truly a mixed venous sample. Excuse me. And then it's ejected out into the pulmonary artery, where we're then able to draw our gas. That is reflective of a true mixed venous gas. Now, in critical care, we don't put PA catheters in patients as much as we used to. So now we do mixed venous gases. We can do mixed venous gases from a central venous catheter. And then we call it SCVO2, right? The saturation of central venous oxygen, which is close to a mixed venous gas. And so we have to realize it's not exactly the same, but it's within a few percentage points of an actual mixed venous gas. And really, when you're looking at a gas or an O2 percentage, you really are following the trends, right? And with a central line being used for a venous blood gas, we are getting as close to a mixed venous sample as we can get without having a PA catheter. And we're looking at the trending value, and we're looking at the difference between what the patient's arterial sat is versus what the venous sat is. And that's really, it's the trending measure that is the most valuable piece of monitoring this. Okay, let's go on to question 4. Which of the following assessment findings would you anticipate in a patient with shock related to a cervical spinal cord injury? Cervical spinal cord injury. Okay, so let's go ahead and go over this. Our answers for this one are pretty mixed. So let's study it a little bit more so that we have a good understanding of it. So when we're talking about a neuro cause, when we're talking about specifically spinal cord cause of neurogenic shock, we are going to see hypotension and bradycardia. Now let's talk about why that is. And I'm going to go ahead and pull up the slide. So here you can see this patient has a cervical spine injury, right? And then over on your right-hand side, you will see the spinal column, okay? You'll see the vertebral column and the spine. Now, we've been taught from little on in nursing, when you think about the autonomic nervous system, the parasympathetic nervous system is often called the cranial sacral branch. And what that means is that parasympathetic nerve fibers exit out of the central nervous system and head out toward the body via the cranium and the sacrum for the parasympathetic nervous system. Whereas the sympathetic nervous system is always referred to as the thoracolumbar division of the autonomic nervous system. Thoracolumbar, which means that the nerve fibers for the sympathetic nervous system exit the cord and head out to the tissues via the thoracolumbar section of the spinal cord. Now, what does that mean? And what does that mean to me, to us, to you? When you have a cord injury in the C-spine area associated with cord edema, we can see a patient who's in the position where, as the patient develops cord edema, there is an interruption in flow and perfusion to the thoracolumbar area of the spinal cord. Now think about it for a second. We just got done saying that the sympathetic nervous system is the thoracolumbar division of the spinal cord. That's where it exits. So if I have a C-spine injury and I have edema and I have essentially wiped out flow to my sympathetic nervous system, which is located below the C-spine, then what's going to happen is the parasympathetic nervous system, which part of that division exits out in the cranial area, is going to kind of take over because there are no sympathetic forces to combat it or balance it out. So what happens is, as you have this very strong parasympathetic influence, what will happen is you're going to have global vasodilation. And with global vasodilation, of course, your blood pressure is going to tank. The normal response in most shock states is when you dump your pressure, of course, the sympathetic nervous system is going to kick in and it's going to increase your pressure, is it not? It's going to increase your pressure by trying to do so through tachycardia. But keep in mind, the sympathetic nervous system is the one that's really kind of non-functional right now. So instead of going tachycardic in response to this drop in blood pressure, what will happen is you'll have this overbearing influence of the parasympathetic nervous system, which results in hypotension and bradycardia. And that's why we see those two things when a patient has a C-spine injury and goes into neurogenic shock as a result of that. And you can be battling that for hours and days after the injury. So it's not something that is like a once and done sort of a thing. All right. Let's go ahead. And you know what? I'm going to scoot over to the chat just very briefly to see if anybody happens to have any questions. I like to get those really quickly before I move on. Looks like everybody's right on target. So let's go to question 5 then. You have been caring for a patient who is admitted with sepsis. She has required intubation and mechanical ventilation to support tissue oxygenation. The ventilator alarm is indicating that there is an increase in airway resistance. The patient displays increased work of breathing. She becomes hypotensive, tachycardic, and is extremely anxious. You should anticipate treating this patient with, and let me pull up the poll. I'm sorry, you might be hearing my dog Henry in the background barking. All right, so let's go ahead and pull up the answers. Okay, so now let's just think about this, okay, guys? You have this patient that is septic. We know that patients who are septic are very thrombogenic. So, or you can just say hypercoagulable. So look, this person is septic. Sepsis activates the clotting cascade. We wind up with microthrombi developing in the microcirculation. So circulatory flow is slowed down. We always say, don't we, that when somebody is septic, we say that there's issues with tissue oxygenation and shunting of blood away from tissues. And that's why we can see sometimes, you walk up to a patient's bedside that's septic and you see, you look at the pulse ox and the pulse ox looks pretty decent. Pulse ox is in the 90s and you say, hey, not half bad. So you see this real pretty looking pulse ox and this not so good looking patient in the bed. So that is a clinical indicator that has to, first of all, make you suspicious that somebody is septic, and you correlate, of course, all of your other assessment findings, but that is very reflective of tissue shunting of oxygenated blood, where the pulse ox looks decent, the patient in the bed does not look decent at all. And so you can see here, as we go down this spectrum, we see that basically making all of these clots, because sepsis is a hypercoagulable state, making all these clots everywhere is basically going to wind up consuming our body's clotting factors. And as our body's clotting factors are consumed, well, now we're in trouble too, because now we're going to bleed, right? When all of our clotting factors are consumed, we're going to start to bleed. And that's why, keep in mind, one of the earliest signs of DIC is when your patient starts oozing around venipuncture sites or traumatic wound sites. Then you really need to stand up and take notice. And so bleeding is a huge issue here. So let me just go back to the question. Now, this person is septic, and yes, we want to jump all over sepsis with fluids. And maybe it probably would have been better for me to have included in that question that the patient has been adequately supported with fluid therapy. I could have added that to the question. But what you have here is a person that has this increase in airway resistance, problems oxygenating, increased work of breathing, hypotension, tachycardia, extremely anxious. Boy, that really sounds like a PE, does it not? And if you look at treatment for PE, we know that, and we're so used to treating PE with anticoagulation therapy, right? I mean, that's something that we do all the time. But you have a patient here that has what looks like a PE and is very, very symptomatic of this PE. In fact, very hemodynamically unstable. They're hypotensive, they're tachycardic, increased airway resistance, they're struggling to breathe, they're very anxious. So we really have to consider the use of thrombolytic therapy to break up clots and try to reestablish flow in this particular patient. Okay, on to question 6. A patient with cardiogenic shock develops a new onset of a holosystolic murmur associated with the following assessment findings. We have a blood pressure of 78/48, heart rate of 156, respiratory rate of 36, right atrial pressure or CVP of 18, PA pressures are 50/30, and the wedge is 26. The O2 sat is drawn from the right atrial port, and it's 60%. And it's compared to a blood draw from the distal port or the PA port, where the saturation is found to be 88%. The critical care nurse would anticipate this as a cause for this finding? Okay, so I have a few different options on this one. So let's go ahead and look at the answer, and then we'll explore further. The answer is ventricular septal rupture, or C, ventricular septal rupture. Now let's talk about this. Let's pull up the illustration. So it says that a patient has new onset of a holosystolic murmur. So what's happening is every time the left ventricle contracts, you can see that pinkish, reddish, oxygenated flow going from the left side of the heart over to the right side of the heart. That is what's giving us the systolic murmur. So it sounds a lot like lub stub, lub stub, lub stub, or stub, 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 stub. And this patient gets in trouble real fast, especially if they have a large ventricular septal rupture or perforation. Now, keep in mind, now, who would you suspect of this? In the question, it said that this patient had cardiogenic shock. So you would think cardiogenic shock related to an MI. What kind of patient would be set up for septal rupture? Well, it's anybody that's had an MI that has involved the septum. So, for example, somebody that comes in with anterior septal MI, anterior septal. Now, the next thing is it says in this story problem, if you will, that blood was drawn from the right atrium and the saturation of the blood in the right atrium was 60%. And that's pretty normal saturation, is it not, in the right atrium? But then it's compared to blood that's drawn out in the pulmonary artery. Now remember, the PA should have venous blood coming from the right ventricle, correct? So technically, from the right atrium to the right ventricle to the pulmonary artery, the saturation should be pretty much the same, because no matter how you look at it, the right side of the heart has deoxygenated blood, and that's what gets pumped out into the pulmonary arteries. So when you look at the story problem, what's not making sense is the fact that it says at the distal port, the saturation is 88%. Very abnormal finding. Like, where did it possibly get oxygen? Well, going back to the slide, it's getting oxygenated blood here from the left ventricle into the right ventricle, and then it's getting pumped out into the pulmonary artery. And so that's called a step up in oxygenation between the right atrium and the right ventricle. And we see that with ventricular septal rupture or a perforation. Now, why wouldn't it be atrial septal rupture? Well, it wouldn't be, because when you looked at the gas in the story problem, the gas in the story problem showed a saturation of 60%. So that's normal in the right atrium. There's no step up in oxygenation in the right atrium. Whereas when we took a look at the gas in the pulmonary artery, or at the tip of the pulmonary artery catheter, we found that there was quite an increase in saturation when actually it should have been quite the same as in the right atrium. The other option, when we look at the rationale, the other option had to do with, let's see, acute papillary muscle rupture. You would not, with acute papillary muscle rupture, you would not be seeing a step up in oxygenation. but rather what you would be seeing is you would be seeing a big, tall V wave in the wedge pressure tracing. And we discussed this, I believe it was last time. You might want to review our content from last time or the time before, perhaps. So session 2 or 3 of cardiovascular. A big V wave is caused by mitral valve insufficiency of any cause, whether it's ruptured papillary muscle, torn cord A, tendon A, or maybe the left ventricle is just so overflooded with fluid that it's pulling on the annulus or the ring around the valve, which makes the leaflets of the mitral valve not able to come together. Either way, it produces a V wave, big, huge V wave. It does not produce a step up in oxygenation. And remember that big, huge V wave is a wave that if you, on your dual tracing, you look at the EKG, the V wave will come up right in the T to P interval. It's important when you look at hemodynamic waveforms that you assess the wave with respect to the EKG waveform that goes with it. Ruptured ventricular free wall, this would be a patient that would have signs and symptoms of tamponade. All right, and here you can see an example post-MI of a patient that has intraventricular septal rupture. So let's move on then to question 7. We now have a 56-year-old female who's admitted to the ICU from a local rehab facility after experiencing fever and general malaise, flu-like symptoms for the past 3 days. Her blood pressure is like 68/44 with a heart rate of 144, and she's chugging along at a respiratory rate of 32. The critical care nurse anticipates the following initial intervention. Yay! It looks like you all got this one for sure, because the Surviving Sepsis Campaign guidelines have basically hit that home to us, right? And that is the first intervention is to get the isotonic IV fluids going. 30 mLs per kg is what we're after, watching patients very closely. I know that critical care nurses are always really worried. All nurses are worried, oh boy, I'm pushing in all this fluid, and this patient has a history of renal failure, or this patient has a history of CHF. Well, really, it's on you then to assess that patient and watch them more closely and listen to their lungs. Because what's going to kill them at this point is the sepsis. And so we need to get the fluid on board as soon as possible. And so we look at the overall fluid requirement, and then we determine, okay, I need to get X amount of fluid in over the next few hours in order to build up the patient's blood volume, because they're massively vasodilated out. Now, again, we're not repleting blood volume per se, but certainly intravascular volume would probably be a better way to say it. Now, within that first, hour, half hour to an hour, if fluid's not doing it, of course, we have to start adding a vasopressor to that. Sometimes if the patient is crashing, we're going to push the fluids as fast as possible and start the vasopressor. But on the CCRN as well as the PCCN, make sure that you know that this is the initial intervention. Now, again, it can be combined with a vasopressor, and Surviving Sepsis Campaign guidelines talk about norepinephrine being the first choice vasopressor for the patient, followed by things like epinephrine infusion and then vasopressin infusion, which has a very different mechanism of action. Dopamine, dopamine has fallen so far from popularity. It's way down the list as far as a vasopressor to be used in sepsis. unless the patient is also bradycardic, because dopamine is infamous for causing tachycardias. So if the patient's bradycardic and needs a vasopressor, then dopamine might be your drug. So when we take a look at total amount of fluid distribution in the body, you see this here, we are very fluid dependent. I always try to hit this home to people because when you take, everything in medicine, it seems, is based on the 19-year-old 70-kilogram male. If you take that 19-year-old 70-kilogram male and you squeeze out every last drop of blood in his body and you put it in a big bucket, the bucket would have to be pretty huge because it would have to hold about 42 liters of fluid. And so we're very fluid dependent. And that's why, as nurses, we always lean toward, when the blood pressure starts going down, do we need fluid? Do we need fluid? We always address that first. And is the patient fluid overloaded, or could that patient use a little fluid bump? All right, moving on then, we get over to question 8. Now we have a trauma patient, and this patient is admitted to the ICU after having received massive transfusion, 6 units of packed red blood cells for hemorrhagic shock. The critical care nurse should anticipate the administration of what next? Great job, guys. Yes, I'm seeing the right answers coming in here. And let's take a look here. Let me pull it up for you. We want to get in there with platelets and fresh frozen plasma, because I want you to think about this for a second, guys, as we're pouring in this massive amount. And, we use, when we talk about blood administration, we use different terms. Like, we say that somebody has received a massive transfusion. That's usually referred to, or defined as, I should say, at least 5 units of cells in an hour. So you're giving that through the rapid transfuser, right? Then we hear the term multiple transfusion, not massive, but multiple transfusion. That's typically defined as the person that requires 6 to 10 units of packed cells in a 24-hour period. So that is how those terms are defined. So here, this guy has rapidly received massive transfusion of 6 units of packed cells. So if we're just giving red blood cells, we have to give along with it the accompanying plasma and coagulation factors. Now, FFP, fresh frozen plasma, is like giving volume, right? You're giving volume with that, along with coagulation factors. So the patient gets 2 nice things: volume and coagulation, or clotting factors. Platelets, well, the patient's getting platelets. That's self-explanatory. So if we continue to just give red cells, and we do nothing to replete the plasma volume with the coagulation or clotting factors and platelets, we're really going to be off balance, are we not? And the patient's going to continue to bleed. Calcium and potassium. Yes, one of the things that we have to consider is calcium, because we know that banked blood it's banked with citrate, and citrate is used as a preservative. The problem with it is that it can bind with calcium and lower the patient's overall calcium level. That's not a good thing. So we do have to address the possibility that the patient needs calcium. Yes, we do. However, the patient does not need, it's unlikely that patient needs potassium. And the reason for that is that when you give banked blood, that bag of blood already has plenty of potassium in it. So as red blood cells break down, they release their potassium, and we have plenty of potassium in a bag of blood that comes to us from the blood bank. So cryoprecipitate. Cryoprecipitate can be incorporated into this process if we feel, for example, a patient's going into DIC, but none of this story problem tells you that. Cryoprecipitate has factors 8, 13, and fibrinogen. So we would really see that incorporated more into treatment when a person has DIC. And then Bumex or a loop diuretic, if the patient is fluid volume overloaded, we could give a diuretic, but again, the very best answer for this particular question is D. Moving on to question 9. Now we have a 27-year-old, and this guy's admitted post motor vehicle collision. He has bruising over the sternal area and muffled heart tones. He's hypotensive, tachycardic, and has jugular venous distension. Which diagnostic study would be best to confirm a diagnosis here? Which study would be the best? Okay, you guys are doing great. Yes, an echo. While all of those tests can be part of the diagnostic profile, the best study that is really going to help us be able to identify fluid in the pericardium, blood in the pericardium, is definitely echo. So remember, when you're taking your test, remember Beck's triad. And Beck's triad is muffled heart tones, neck vein distension. You can see here that the person has neck vein distension, and then hypotension, particularly pulsus paradoxus, where as the patient breathes in, and by the way, we all know that pulsus paradoxus is the easiest thing to pick up when you have an arterial line in place, because what you see is as the patient breathes in, you see that the blood pressure systolic drops by at least 10 millimeters of mercury associated with every inspiratory effort. And that's because if you think physiologically, when we breathe in, that negative pressure increases venous flow to the heart. So every time we breathe in, there's an increase in venous return. If you have a heart, and you can see the heart here that it has fluid, perhaps blood in it, that is actually compressing the heart on all sides, what we would wind up seeing in this case is that the systolic pressure would drop, because this is like an obstructive form of shock where the heart cannot fill normally. It is a filling defect because the heart is being compressed on all sides by the fluid that's accumulating, or blood, in the pericardial sac. Another thing I want to mention is when you take the CCRN exam, if you find a patient with this kind of symptomatology and you notice that the patient has equalization of chamber pressures, so the CVP climbs up, meeting the wedge or PA diastolic pressure associated with findings, that also is a clinical indicator of cardiac tamponade when somebody has a PA catheter in place. So, echo is the answer. And our last question today, you have a patient with neurogenic shock who has a heart rate of 32. Which of the following would be administered to reverse the effects of the parasympathetic nervous system? Okay, let's go ahead and pull up the answer here. The answer is atropine. Now, why is that? If you remember, we talked about spinal shock, right? And we said that the parasympathetic nervous system has an increased amount of activity. The sympathetic and parasympathetic are not in balance. The sympathetic nervous system is overcome by the parasympathetic. So when you look at atropine is a vagolytic drug or a parasympatholytic drug, meaning it lyses the effect or decreases the effect of the parasympathetic nervous system in hopes that we can bring the heart rate up. Dopamine, however, that was another choice that people chose. Dopamine works on the sympathetic nervous system. It really does. And you're not going to probably get a whole lot of bang for your buck, but it could be used. Why could it be used? It could be used for vasoconstrictive effects. And again, to try and use catecholamines in order to try and get the most bang for your buck you can get out of the sympathetic nervous system. Epinephrine, we see that in spinal cord injured patients all the time because it's a nice vasoconstrictor to bring pressure up. But the question is asking you, what drug will reverse the effects of the parasympathetic nervous system? And the only drug there that reverses the parasympathetic nervous system effects, or the parasympathetic nervous system period, is atropine. The rest of it, I guess, would have just kind of it wouldn't have a direct effect on the parasympathetic nervous system, epinephrine and dopamine, but would rather try to increase catecholamine activity. So kind of a different mechanism. So guys, that is it for today. I would like to ask a favor of you all, and that is if you could please head on over at some point to my YouTube channel and please subscribe. I am shooting for 1,000 subscribers, and I ask your help in getting the word out to other critical care and progressive care nurses about my YouTube channel. I'm going to be putting all of my podcasts on that channel as well. I've already uploaded, I think, 5 of them. So please help me spread the word. Please have your friends subscribe if you think that the information I've been providing you is valuable. I also, if you need help on your CCRN or PCCN course, I also have 2 courses available online, and you can head over to my website, Hoppy Presents, in order to view the content of both of those online programs, and you can order either one if you feel as though it will help you. In order to thank you for your time today and your participation, I'd like to offer you a discount on either the CCRN or the PCCN. And what you need to do is, again, go over to my website. You have it listed here. And then choose which one you want, the CCRN or PCCN. And should it meet your needs and you think it'll be helpful to you and would like to purchase it, put in this code 042623, which is the date today, webinar, and you will receive a $100 discount on either the PCCN or the CCRN. So I think it's a real good buy. A lot of information, 30 continuing education hours, guys. So all of my continuing education hours are accredited. You get note-taking guides for every topic. Unlike other programs out there, I have unlimited access 24/7, 365 for life. So there's never a time where I say, okay, this is done, and shut it down where you can't listen to it anymore. Also, as I update my review programs, you'll automatically get those updates. So thank you very much, everybody. And if you'd be so kind as to give me some feedback in the chat, I'm always wanting to know if you have any suggestions, or if I want to make sure that you enjoyed the program. So it would be wonderful if you gave me an evaluation in the chat. So thank you all for being here. Thank you, Ethel and David, Carla, Phyllis, Eileen, thank you, Becky, Thanks to all of you guys. I really very much appreciate it. LaShandri, thank you very much. Heidi, you're awesome too. Thank you for coming. Glad you guys like the reviews. That's really wonderful. So take care and have a blessed day, everybody. I'm signing out. Bye-bye.